Hi, my name is J. Marie Ramos, and I'm going to be doing research related to inductions of labor and maternal/perinatal outcomes. For my introduction, induction is a method of provoking labor through various methods to achieve childbirth. Induction is considered a medical intervention. This topic was chosen due to the increase in elective inductions in the United States. Induction of labor was typically reserved for women who were post-dates 40 to 42 weeks gestation, or if they had other risk factors that indicated earlier delivery, such as chronic hypertension, gestational diabetes, cholestasis, or low fluids. Currently, there has been an increase in elective inductions, which I stated already. But does the data support these elective inductions prior to due date? Does inducing a patient prior to her due date pose risk to mom and baby by intervening medically if we do not have to? A recent study showed that overall frequency of labor induction more than doubled in the United States, increasing from 9.5% in 1990 to 23.8% in 2010. And elective induction for the mother and provider's convenience accounted for approximately 40% of cases. For my research question, do inductions of labor result in increased C-section rates and adverse patient outcomes? For the PICO, for my P, the population is pregnant women close to due date, 39 to 42 weeks. The intervention is inducing patient when compared to women who go into labor on their own. And then my outcome is evaluating cesarean rates and perinatal outcomes when compared to inductions. So my research question in the end is, in pregnant women, what effect does induction of labors have on C-section rates and perinatal outcomes when compared to women who spontaneously go into labor? For the literature search, the terms that were used to locate the data were inductions of labor, cesarean rates in labor patients, spontaneous labor, 39 weeks gestation, induction, perinatal outcomes, maternal outcomes, and delivery. I was able to find my data relatively easy using these search engine keys. This is an emergent topic in women's health, so there is a lot of newer studies currently, which helps, but it also conflicts some of the older studies that are out there. The articles that I chose involved a lot of randomized trials. I chose this type of data to make sure that I was choosing good solid studies that involved real people and similar real-life scenarios. Randomized trials also allowed me to evaluate the data that is out there on cause and effect between the treatment, which is the induction, and the outcomes that we were evaluating. So for the literature synthesis on these articles, so a lot of the data that I found initially when they're going through the study, they did state that they had conflicting studies. So what their data showed was different than previous data that was obtained in other studies. So for the data that I selected, I chose a lot of studies that were that revolved around women who were 39 weeks pregnant and who never gave birth before. I also chose articles related to women who went into labor on their own versus being induced. And then I also looked at articles that looked at the outcomes for mom and for baby to determine the risk of induction patients and the benefits it provides. And I found some really good studies that went into detail for all of these. So for a lot of the articles that I had, it showed that C-section rates did not increase in women who had unfavorable Bishop scores and were induced at 39 weeks. In Kim et al. 2019, it showed that maternal outcomes were similar to those in spontaneous labor. And in both Miller et al. And Kim et al., they both used very small study groups, which was 162 and 237 patients. Now, for my study that was done by Grobman et al., they were able to obtain 6,000 patients for their study, which was one of the most solid studies that I had in my literature research, which showed that the outcomes for mom and for baby were the same for patients who had labor induction versus patients who went the other route, which was expectant management after they were past their due date. So currently there's more research that has to be collected to see if C-section rates are increased in women who are induced. For Miller et al. 2015 and Grobe et al. 2018, the results were more reliable considering they both used randomized trials. So once again, for 3 of my studies, it showed that, actually 4 of my studies, it showed that adverse outcomes for maternal and infant did not increase due to induction of labor. In Sabragman et al. 2014, I'm sorry if I do not know how to pronounce that name correctly, higher rates of C-sections were noted in obese women, regardless if they were induced or not. But these women also had high comorbidities, meaning they were already starting off in a bad place prior to the induction, which already put them at a higher risk to have risk factors, if that makes sense. I would say consistently throughout all 5 research articles, there was methods of inductions. All the methods of inductions were different. So how they choose to induce the patients were not the same, and no protocol was consistent. They also noted that Bishop scores were important in determining whether induction was favorable or not. And they also all used different demographics for their studies, and most of the women did not give birth before. For one of my studies in Grobe et al., while I was looking at the demographic data, although they stated that the data did not show any differences in the outcomes for mom, whether they were induced or whether they were in the expectant management, I did notice that a lot of the patients were either obese or smokers, which puts them at a higher risk to have comorbidities. So my concern with that data study was, did the patients have these adverse outcomes because they were induced or because they were already unhealthy? So did that skew their results to look like inducing them was the better option versus the expectant management, which could have led to adverse reactions as well because they were already unhealthy? So I hope that makes sense. Also, for my literature synthesis, induction had good outcomes with patients who had comorbidities. So the practice / management recommendation in multiple studies, all of the studies that I use, they recommended that 39-week inductions were favorable for patients and did not increase adverse outcomes / C-section rates. Also, ACOG, which is one of the biggest coalitions, you'd say, for women's health, they also endorse that 39-week inductions are generally safe for mom and for baby, given that the reason that you're inducing the patient outweighs, it will end up benefiting the patient. With that being said, although they recognize that 39-week inductions do not increase adverse outcomes / C-section rates, for my evidence-based practice, I would consider that we need to look at more data that needs to look at patients who are truly healthy and who don't have these high risk factors, and they're just being induced because it's an elective induction. So yes, a lot of the studies do state that elective inductions do not pose any risk to mom and baby if they have all of these risk factors. But what about the patients who are genuinely healthy, do not have any risk factors, and they're being induced electively? There's still not a lot of data on that, so we'll have to see. Also, there was no induction protocol for any of these 5 studies. They all had different induction protocols on how they wanted to manage the patients, which if they are going to be leaning towards the 39-week inductions for patients, maybe coming up with a protocol for the United States that they would follow to maybe lower outcomes and increase good maternal outcomes for patients and for baby. I would say a barrier that I found to the practice management is that labor is an event that occurs spontaneously. So although data supports inductions of labors, should we interfere with an event that is supposed to occur naturally if there are truly no indications to support induction? So this is for the moms who are healthy, who are close to their due dates, and they're recognizing, hey, 39-week inductions are supposed to be healthy now. Can I be induced? What are we going to tell these patients if they truly have no reason to be induced? Or is all of our patients going to be induced now, leaning towards the future? So I'm concerned about what the practice of healthcare is going to look like for labor and delivery if we're doing so many medical interventions in a process that's supposed to occur naturally. And for the conclusion, data supports induction of labor at 39 weeks and states that C-section rates do not increase due to inductions. Maternal and perinatal outcomes were similar to those being induced versus women who went into labor on their own or women who had expectant management after their due date. So they were already 40 weeks and they were being managed until they were 41 weeks, not being induced in the hospital. More data needs to be collected on spontaneous labor outcomes and long-term effects on induction of labors for first-time moms. So if a mom is being induced for the first time and she never allowed her body to naturally go into labor, does this add any risk factors for any of her future pregnancies? Will she need to be induced every single time? Is there studies out there that show risk factors for those moms who were induced the first time and then needed to be induced the second, third, and fourth time? What does that look like for our patients? And here I have listed my references. Thank you.